Good evening, everyone. Thank you so much for joining us for part two of the Caribbean College of Family Physicians Jamaica chapter's Glaucoma webinar series. Of course, the theme is Clarity in Sight, Advancing Eye Health and Glaucoma Management. We thank you so much for taking the time out today, Thursday, the 20th of February, 2025, to come and have a conversation with us and learn. I'm going to hand you over now to our moderator for this evening, Dr. Pauline Williams Green. Dr. Williams Green, over to you.
Thank you, Sam. Good evening, everyone, wherever you are, and welcome to the Caribbean College of Family Physicians Jamaican chapter webinar. And the title is so exciting, all about clarity in sight. We're going to start right away with a prayer by Dr. Arlene Henry Dawkins, who is a member of the executive.
Good evening, everyone. Let us pray. Almighty and loving Father, we praise, honor, and adore you, and thank you for the goodness, mercy, and blessings showered on us daily. We thank you for another opportunity to gather virtually on this ophthalmology seminar hosted by the Caribbean College of Family Physicians, Jamaica. We invite the precious Holy Spirit to be present in all aspects of the proceedings tonight. May He graciously guide all our presenters as they share expert knowledge on the various aspects of this topic with clarity, practicality, and relevance. May He keep our thoughts focused and alert, increase our understanding, and enlighten our minds as we absorb all the information shared on this potentially devastating disorder of the eyes. Enable us, we pray, to effectively use all we learn tonight for the best outcome as we diligently care for our patients. We humbly pray for an uninterrupted flow of this meeting without glitches and technical difficulties as you pour your blessings on the moderator, the sponsors, the audiovisual personnel, the administrator, and all participants. May this seminar be productive and fruitful, resulting in strengthening our efforts towards greater achievements in early detection and management of this seriously life-changing eye disease. Remember all those who are afflicted and living with this condition, and may they be assisted with all possible interventions to restore vision and improve their quality of life. All these we ask in the wonderful name of Jesus Christ, as we thank you, Father God, for this precious time you have given us together tonight. Amen.
And amen. Thank you so much, Dr. Arlene Henry Dawkins. We will now receive the greetings and welcome from Dr. Seni Onanuju, the president of the CCFP Jamaica chapter.
Good evening, colleagues, distinguished presenters, moderators, and esteemed guests. It is my pleasure and honor to welcome you once again to the final session of a two-part CME seminar on ophthalmology, glaucoma. Last evening, we explored comprehensive and critical updates in glaucoma diagnosis, treatment, and management, equipping us with valuable knowledge to enhance patient care and preserve vision. Tonight, we continue this important discussion with another insightful session. I extend my deepest appreciation to our expert presenters who shared their insights yesterday. To our special presenters joining us this evening, thank you for graciously dedicating your time and expertise to close this important discussion. Your knowledge and contributions will further enrich our understanding, and we are truly grateful. To our moderators, thank you for skillfully guiding our discussions and ensuring meaningful engagement. To our secretariat staff and IT team, your behind-the-scenes efforts have made this event seamless, and we deeply appreciate your hard work. A special thank you as well to our accreditation and programs committee members, our CCFPJ chapter colleagues, and most importantly, you, our attendees. Your participation, curiosity, and commitment to continuing medical education make these sessions impactful and rewarding. I also wish to extend a special commendation once again to Dr. Maynard McIntosh, whose invaluable efforts in the planning process have helped to make this event a success. Finally, we express our sincere gratitude to Indus, our event sponsor, for their ongoing support of CCFP's educational initiatives. Your partnership in advancing healthcare education is fully appreciated. Likewise, we extend our gratitude to Indies Farmer, who is joining us this evening. As we conclude this seminar, let us carry forward the knowledge, discussions, and best practices shared over these 2 days and integrate them into our daily practices. Thank you for your engagement, and I encourage you to continue seeking opportunities for learning and professional growth. It has been an honor to share this experience with you. Wishing you safe practice, good health, and I look forward to see you at our next CME event. Thank you, and have a wonderful evening. And as always, God's richest blessings.
Thank you so much, Dr. Onanuju, for your untiring service to the CCFP, and bless you too. So we're going to go right into it. Dr. Lloyd Williams is our next presenter. He speaks on neuroprotection in glaucoma management, the role of emerging therapies in preserving optic nerve function, and just some information on Dr. Williams. And really, let me reinforce what Dr. Onanuju said. Dr. McIntosh has pulled a fantastic team from Duke University. We really appreciate it. Would you believe Dr. Williams began his career in engineering, and after completing bachelor's and master's degrees in material science and engineering, he went into medical research as an engineer, and then went on to complete a master's degree in physiology and a PhD in neuroscience. And he is very involved in eye care. Let me just get my notes. I just saw down there was what he said was so important. I didn't want to leave that out. He's the director of the Duke Global Ophthalmology Program called Duke Gold. And just to let you know, he has done thousands of cataract surgeries in Africa, Sudan as well, and other parts of the world. And he has done the very first ever corneal transplant in Sierra Leone in 2021. But without further ado, let me just welcome Dr. Lloyd Williams, who is also the president-elect of the North Carolina Society of Eye Physicians and Surgeons. Let us welcome him, because we don't want to limit his time as he tells us about neuroprotection in glaucoma management. Please go ahead, Dr. Williams. You have to unmute.
And I'll just share my screen here. All right, so today I'm going to talk about neuroprotection and glaucoma management and the role of emerging therapies in preserving optic nerve function. And just welcome to the Caribbean College of Family Physicians. It's Duke Global Ophthalmology. We're super excited to get a chance to work with you and discuss one of the most important eye diseases in the world, glaucoma, because of course, glaucoma, once you lose vision due to glaucoma, there's nothing that anyone can do in the first world or the developing world or anywhere that we know to recover that vision. So it's so important to prevent people from losing vision. We've been doing questions, so we'll ask the question at the beginning and then we'll review the answer at the end. Question 1, what causes glaucoma? So A, elevated intraocular pressure. B, decreased perfusion of the optic nerve. C, glaucoma is multifactorial in its causes and presentation. And D, all of the above. And question 2 is what treatments are well studied and in the standard of care for glaucoma? Oral intraocular pressure lowering agents like acetazolamide, oral blood pressure medications like calcium channel blockers, topical intraocular pressure lowering agents, A and C or E, all of the above. So you probably gathered this from Dr. McIntosh's presentations earlier on the previous day. What is glaucoma? It's actually kind of hard to describe because glaucoma technically is a progressive optic neuropathy. And it is associated with high eye pressure, but not all people who have glaucoma have high eye pressure, and not all people with high eye pressure have glaucoma. We've talked about how there is open and closed angle glaucoma, and both of those are actually in some ways really quite different diseases, and the treatments can be quite different. Most closed angle glaucoma is treated surgically, at least on some level, and a lot of open angle glaucoma is treated medically. There are many special cases of glaucoma, and pictured here are phacomorphic glaucoma, glaucoma from a hyphema, and glaucoma from pseudoexfoliation. But there are actually dozens and dozens of glaucoma syndromes where either material is generated in the eye that plugs up to trabecular meshwork, or medications like steroids can cause increased pressure, or structural changes like a very large lens can push the iris forward and close the angle and cause glaucoma. Infections can cause glaucoma. There are a variety of inflammations like Fuchs heterochromic iridocyclitis, and on and on and on. So glaucoma is actually many different things. But most of the time when we're talking about glaucoma, just in general, we mean primary open angle glaucoma, which Dr. Gupta discussed yesterday. And that is, as was discussed, that is a diagnosis of exclusion. If it's not any of the other things and the angle is open, then it's primary open angle glaucoma. And that is actually probably the most common. And then we also discussed pediatric glaucoma yesterday, and the factors that cause pediatric glaucoma are themselves another set of types of glaucoma. In my own mind, when I think about glaucoma, I tend to think of it as a balance between the perfusion pressure of the optic nerve and the intraocular pressure of the eye. And so if the intraocular pressure is at a level that's high enough to reduce the perfusion pressure of the optic nerve, then you get slow damage to the optic nerve. Or in some cases, like angle closure glaucoma, or some of the glaucoma syndromes where the pressure goes high very quickly, you can actually shut all blood flow to the nerve off when the eye pressure is like 80 or something like that, and kill the nerve actually quite quickly. But either way, in general, the way I think of glaucoma is as a disease of mismatch between the blood pressure, and the intraocular pressure, leading to decreased perfusion and slow or sudden death of the optic nerve. And so the question then becomes, are there ways that, I'll go back here. We talked a lot about how to treat glaucoma by lowering intraocular pressure. But could we in fact work on this side of things, the perfusion pressure or protection of the nerve from intraocular pressure, or some other factor besides intraocular pressure in terms of our ability to treat or prevent glaucoma? So one of the things that's been studied in this area is different nerve growth factors. Now, we do actually use nerve growth factors in the field of cornea where I work. Sometimes people have poor sensation in their eye and it causes breakdown of the cornea. And we have a drug that in the United States is called oxervate that we use to treat patients with neurotrophic keratopathy. And it is a human recombinant nerve growth factor. And used as an eye drop, it actually regrows or stimulates growth of nerves into the cornea and restores sensation and often heals the surface of the eye. So people have said, well, could we do that at the level of the retinal ganglion cells or RGCs, or at the level of the optic nerve cells that are going from the eye to the brain? And so people have looked at brain-derived neurotrophic factor and other nerve growth factors. In animal models, looking at crush injuries to the nerve or pressure injuries to the nerve, the neurotrophic factors have demonstrated protection from nerve death. However, these studies, in these animal studies, it required repeated intravitreal injections into the eye. Now, as you know, we do repeated intravitreal injections into the eye for things like macular degeneration and sometimes diabetic retinopathy and some other retina conditions. But those intravitreal injections are not without risk. People sometimes get infections in the eye, like endophthalmitis, which can lead to loss of the eye and loss of all vision. The injections can be somewhat painful for patients, and overall, patients don't really like getting a needle stuck in their eye, as you might imagine. Currently, there are no depot injections available for nerve growth factors, where you might be able to do, say, 1 injection per year, which would probably be a level of injection that would have a reasonable amount of risk. So overall, nerve growth factors would need to be injectable in order to reach the target cells. And they show potential, quite a lot of potential in animal models, but currently drug delivery is a problem for these in human trials. And there haven't been any human trials that have shown that this is a treatment that we can begin using in glaucoma patients. So early stages here. Ginkgo biloba, it's a supplement that people take. Actually, people take it for a lot of things. And so some people have said, well, maybe this would help glaucoma. And there have been several studies on this that have shown improved visual field in normal tension glaucoma, decreased progression of visual field loss, and increased papillary blood vessel density, which has been shown to be correlated with decreased optic nerve loss. So all good things. However, other studies, like the study by Guo et al. In 2014, did not show any change in visual fields or progression with ginkgo biloba oral treatment. And so the fact that some of these studies were unable to be replicated is a little bit concerning. And I think at this moment, what we would say in the field of glaucoma is we're not really sure if ginkgo biloba makes a difference or not. I think we haven't seen toxicity or problems with patients. So if people are taking it, I don't think that's necessarily a bad thing. But it's not something that I would tell a patient, don't worry about your glaucoma medications, just take ginkgo biloba instead. I think that would be a bad plan. Brimonidine. Now, brimonidine is a drug that we use in patients with glaucoma all the time. And this is one of the, just most primary standard glaucoma drops in the world. And one of the interesting things about brimonidine is, in addition to lowering pressure, there have been studies that show that brimonidine may also have an effect on NMDA and glutamate toxicity in the nerve, actually leading to neuroprotection. And so several studies have shown that there was less progression in a brimonidine group than a timolol topical group, despite the same reduction in intraocular pressure between the two groups, suggesting that brimonidine does in fact add an extra level of neuroprotection. The problem with a lot of these studies, though, was that the brimonidine group tends to have a high dropout rate, quite a bit higher than the timolol group. And the reason for that is that brimonidine has a higher rate of allergy and ocular irritation. So in the patients who tolerate brimonidine and who don't have allergy to brimonidine, it probably does have a neuroprotective effect and may be a great drop to have patients on for that purpose. But you have to see who's able to tolerate it and who isn't. Calcium channel blockers have been shown in animal studies and others to decrease hypoxic calcium influx into neurons in the optic nerve and reduce the rate of cell death in retinal ganglion cells and increase blood flow to these cells. So randomized controlled trials of nifedipine and rovincamine have both suggested that there may be some benefit to using calcium channel blockers in patients with glaucoma. And people have also, because calcium channel blockers are really quite common, people have also looked at just retrospective studies. I have all these glaucoma patients and these glaucoma patients. These ones are taking calcium channel blockers and these ones aren't. Was there a difference between one group and the other in terms of who had progression? And what they found is that overall, there does seem to be some increased perfusion and some protective effects regarding glaucoma of calcium channel blockers. However, there is a downside, and you may know that some patients who are on antihypertensives, especially patients who use them at night, can get a condition called non-arteritic ischemic optic neuropathy from low blood pressure overnight. And if the blood pressure is too low, then we would actually expect a calcium channel blocker to work against a patient with glaucoma and possibly actually increase the rate of optic nerve damage. So calcium channel blockers may be beneficial, but they should be used with caution because they also have the potential of increasing the damage to the optic nerve by reducing perfusion pressure by lowering the blood pressure. Memantine has been suggested. This is a NMDA receptor antagonist that we believe could decrease glutamate toxicity in retinal ganglion cells. It showed promise in animal studies. However, a 4-year human trial did not show a change in visual fields. So at this point, we aren't recommending memantine in glaucoma patients. However, it's not 100% clear when you look only at visual fields. Perhaps if they'd looked at OCT or something else, they might have been able to see some changes. Acetylcholine in animal studies preserves sphingomyelin and cardiolipin in neurons, which decrease glutamate toxicity. Randomized controlled trials of acetylcholine showed decreased visual field loss over 3 years and an improvement in ERG and VEP. Now, ERG and VEP, just for the family physicians and non-ophthalmologists, visual field is a test where patients look at something and then click a button when they see a light, and the light shines in different places, and you look and see how well did they do. The problem with visual field is that it requires patient input. So if the patient falls asleep, gets bored, gets distracted, or doesn't understand the test, you can get results that aren't very good. ERG and VEP are electrical studies of the actual retina and optic nerve function and don't require patient input. So in that sense, although they aren't directly measuring vision by saying, hey, can you see this? They can provide information that doesn't require patient input and in some ways may be more accurate. So overall, we as a field felt like these are somewhat promising results, and larger studies are underway, and we're waiting to see what the results of those studies are. Vitamin B3 in mouse studies seem to improve ERG independent of intraocular pressure, and increased NAD in mice in a mouse model of glaucoma, which we would expect to be a neuroprotective function. We think nicotinamide also, like citicoline, may be useful, but further larger studies and randomized control trials would be needed. Again, because nicotinamide is a vitamin B, it seems reasonable that if you had a glaucoma patient who wanted to supplement with this, that there should be no problem with that. And in addition to that, if you had a patient who had, say, low vitamin B3 or something, having them supplement with it would make sense. But I don't think at this point we have enough information to say, yes, this is something that all glaucoma patients should take. Coenzyme Q10 also reduced glutamate toxicity and apoptosis in rats, and large randomized controlled trials are underway to see if this supplement also will help it as a neuroprotective agent in glaucoma. But again, like the last two, we're not 100% sure how effective it is, but we also think that there's not much likelihood of harm from it. Statins are a drug, of course, that a lot of people are taking that reduce hypercholesterolemia, and meta-analyses have shown a relationship between glaucoma and hypercholesterolemia and glaucoma and low high-density lipoproteins. In rat models, statins have improved glaucoma progression, and but at the same time, in human models, we haven't seen a demonstrable change in progression risk when we do larger meta-analysis. So at this point, I think what we could say about statins is if your patient needs statins from a cholesterol standpoint, then use them. And if it's purely for glaucoma, we don't have the data to say that this is going to make a difference. In the future, we hope to have stem cells to be able to actually cause recovery of visual field loss in glaucoma and improve things or bring back vision that people have lost. And in animal models, we've been relatively successful with this. And as you probably know, just from reading research, there's a lot of things that we've been successful with in animal models. And then when it comes to translating it into humans, can't quite figure out that next step. And gene therapy is another one of those, and we'll talk about that next. People have tried stem cells in glaucoma and in AMD, and thus far there has not been any improvements in vision, but there have been retinal detachments, proliferative vitreoretinopathy, and other harm done to eyes. So overall, I think stem cells are something where there's a long way to go before we're ready to use them in glaucoma. And gene therapy, similar. We know that the myocilin gene is a promising target. It's involved in juvenile glaucoma in humans. and it's also involved in the steroid response glaucoma. But gene therapy still in its infancy, and most glaucoma, primary open angle in specific, is probably polygenetic, and it's hard to know what exactly ought to be targeted. So probably a ways to go in gene therapy. So back to our questions. Question 1, what causes glaucoma? All of the above. Elevated intraocular pressure, perfusion of the optic nerve, and it's multifactorial in its causes and presentation. And question 2, what treatments are well studied in the standard of care? A and C. All of the other things that I presented today really haven't entered standard of care for glaucoma. So basically our treatments for glaucoma today are lasers, surgical, topical intraocular pressure lowering agents, and oral intraocular pressure lowering agents, along with some new injectable and sort of depot intraocular pressure lowering agents. And I just put something here at the bottom for people who may want more information. I did my residency at the University of Utah, and the Moran Corps at the University of Utah is a great depot of lectures and information about glaucoma and other eye diseases. And I think you'd find a lot of really good information there that I helped build that website, so that people around the world could get some of the same information that's being presented at the top universities in the US. All right, thank you all.
Thank you so much, Dr. Williams. Excellent presentation and so clear and well put together and relevant points for us as GPs and non-ophthalmologists. I think it was perfectly aimed at the audience. Thank you so much. Please don't go away or fall asleep, because we're going to be doing the questions at the end. All right? So we're going to be moving right along to our next speaker, who is no stranger to us. He was here yesterday, Dr. Nathaniel Blecher. Is he here, Sam?
Yes, he is.
Hey, guys.
Okay. Okay, wonderful. Good to see you again. Thanks. You were introduced, but just for those that were not there last night, here you are. Okay, so Dr. Blecher has a passion for teaching and training, and so he's exposing today. Did medical school at the University of Pittsburgh, and he started or helped to start an ophthalmology lecture series for medical students. And also he is a postgraduate. Where the chief resident is a separate postgraduate year. Oh yes, dedicated to supervising inpatient consult service. He went on to complete a year as the chief, which has motivated his interest to remain in academic medicine, and we're happy for that. He's currently completing a fellowship in glaucoma at Duke. I found him an excellent presenter, very on point, and we're looking forward to his presentation. Please go right ahead, Dr. Blecher, as you speak about lifestyle and eye health, the role of nutrition, exercise, and protective strategies in preventing or reducing the risk of glaucoma. Thank you.
Awesome. Alrighty, guys. So I hopefully have my screen shared in a way that you guys can see the relevant portion of the PowerPoint here. So I'll go ahead and get started for us. So pre-test question. Luckily, Dr. Williams already touched on a lot of these things. So this will be some trod ground. But what's a supplement that can temporarily improve visual field function? And those are our answer choices there. One thing that this portion of the talk will focus on a little bit more, I'll go over some of the supplements that were reviewed, but just briefly at the end. But more so, a lot of patients will ask, are there things aside from medicine I can do to help glaucoma, or is there a particular supplement that helps? And again, sort of some of those first parts of that question we'll cover aside from Dr. Williams' excellent talk that he just gave there. Because there are some other lifestyle considerations aside from just supplements, including things like exercise, mindfulness, or meditation, and then the role of caffeine and how it can affect eye pressure and glaucoma. All right, we seem to be hitting a couple of forwards at a time here. A lot of the information that I'm going to present in this talk came from this excellent review by Dr. O that touched on many different types of lifestyle factors and their effect on glaucoma. So to start off with the exercise component that I brought up here, what's the role of aerobic exercise? We know that it's very helpful for many other aspects of medicine, including cardiovascular disease, but does it have a role in protecting the eye from glaucoma? Luckily, this has been something that's been studied fairly extensively, both in animal and human models. As far as the animal models, this paper is a good example of what their proposed mechanism here is, that essentially by having aerobic exercise, you're increasing the brain-derived neuroprotective factors that might cause a reduction of oxidative stress and possible neuroprotection. So this whole idea is that, the glaucoma is caused due to damage to a nerve. And so if you increase these protection factors, you are preventing nerve damage and thus preventing glaucoma. And that is, really the root cause of what's coming on here, rather than just the eye pressure. A lot of the times what we like to say is eye pressure is sort of just a number. There are plenty of folks walking around out there with eye pressures in the 20s who never go on to develop glaucoma. And so there's something deeper at the root of it, and it's likely some sort of direct neurotoxicity or damage there, or issue with a higher proclivity to damage. So anything that can protect that nerve is going to prevent progression of glaucoma. But how does this pan out for humans themselves? And so they've done studies in this as well, including a prospective cohort study where different patients were broken up into groups and assigned to moderate or vigorous activity in terms of counting their steps per day. And then followed up over the course of 5 years. And what they showed is that folks who are in the higher activity groups had less visual field progression. They've also done, comparative retrospective studies of folks who are in higher or lower physical activity groups. And what they suggested is folks with some moderate physical activity had much less progressive visual field loss. One thing I'll comment on this before moving on, obviously there's a lot of potential confounders. People who tend to be more active might have different access or ability to continue to follow up. And there's a lot of potential other confounding factors that are affecting this data. Another thing to think about is mindfulness. So the idea that stress reduction through meditation or taking gaps in your day to focus on mindfulness might be beneficial for both eye pressure and glaucoma in general. This is something that's it's somewhat difficult to quantify, but there are scores and scales that try to assess somebody's level of stress and thus sort of quantify maybe the impact of meditation or mindfulness from the actual stress side of things. And then, of course, we have our pressure and visual fields that we can use as a correlate for glaucoma. So when comparing those two things, there was an interesting randomized controlled trial that was published, particularly breaking folks up into groups that either were practicing this mindfulness or not. And what it showed was there was a significant reduction of eye pressure, about a mean of 2 points, a little less than 2 points, and an increase of vessels around the nerve itself. And this is just that study itself. What they did is they had people who were broken up into the mindfulness group practice daily meditation. for 21 days. And this was 60 minutes, 15 minutes of breathing exercises followed by 45 minutes of meditation. And then they took their eye pressure several times throughout the day, as well as collected blood samples. There's a lot of data they put out about this, including a lot of blood data that has been associated with stress and markers of stress in the body, like cortisol and TNF alpha. But probably what's a little bit more relevant for what we were just talking about are these two factors up here, eye pressure, and then that brain-derived neuroprotective factor. And so what they were positing is that this reduction of stress can lower all these markers of inflammation and stress within the body, and then that could be useful for glaucoma itself. They proposed it as an adjunctive therapy, so not a replacement for anything, but in addition to regular glaucoma treatment. This was not a double-blind study. It's kind of hard to tell somebody that they're in the mindfulness group and then have them fake meditate. So that is a limitation. And it was obviously very short. You know, they were just testing this throughout the day, and they were only doing this while people were actively participating. So how long does this last, or how durable is the treatment, remains to be seen, and whether or not this actually has any play out to, again, the important part rather than the pressure, the visual field, remains to be seen as well. And so caffeine is another thing that people ask about a lot. You know, aside from stress being noted, anytime I check out pressure and it's higher than the patient was anticipating, they either tell me that they are stressed that day or that they just had their coffee. And there is some truth to that. It turns out that if you give somebody a bolus of caffeine, it can raise the pressure, both short term and a little bit a couple hours out. And that beta blockers actually tend to blunt this effect of caffeine. And what they show is that different levels of caffeine and these other studies also have different levels of effect, and that people with glaucoma are actually more sensitive to caffeine than folks without glaucoma. And then this was another interesting study that looked at this. And they, rather than bolusing folks with caffeine, they just broke people up into people who drink coffee and people who don't drink coffee, and checked their eye pressures and showed that there was a fairly significant difference. They adjusted this too for other age and gender factors, things like that, and it didn't quite reach significance, but it was still trending towards a difference. And then finally, I won't spend too much time on this since we already talked about it a little bit. But nicotinamide is probably one of the supplements that has some of the hardest evidence in terms of randomized control trials and visual field testing in terms of actually having an effect on the visual fields. But this has only been shown, again, over 2 to 3 months. And interesting, was only for people who had mild or moderate sensitivity loss, so not folks with more advanced glaucoma. And this is just a demonstrating why that might be useful, again, from nicotinamide's role in the body. So in conclusion, you know, when people are asking about different things that can affect their eye pressure or their glaucoma, there's decent evidence for aerobic exercise. There's some short-term evidence for pressure for mindfulness or meditation, though not a lot of evidence in terms of fields itself. Caffeine does probably affect eye pressure. So if it's something that people are doing right before their appointments, it could certainly have an effect. And then we don't have a ton of data on which supplements might be more useful for actual treatments. But, you know, I never discourage folks from taking supplements, and there's possibly some mild improvement with especially nicotinamide. So if somebody is very interested in anything that they can take as an additional supplementation, I don't think this is a bad one to say that it might be useful. But again, none of these are replacements for glaucoma treatment, but might just be useful adjunctive therapies. So to circle back to our initial question, what supplement can temporarily improve visual field function? And for this one, it was nicotinamide. So I just want to say a very big thank you to Dr. Lucy Hui for her significant contributions to this talk. And a thank you again to everyone here for having me as a speaker.
Thanks too, again, Dr. Blesher, and you just brought us back on track. We're on time. So we thank you. And yes, that was really very enlightening. And so now when my patients come with their supplements that were sent by their relatives in the US, I won't turn up my nose. I will certainly look at them and see what they have. So moving right along, since we're on time, we're now going to ask Dr. Stephen Karuba, consultant ophthalmologist, to join us. And let me get my notes out, and he's ready and waiting. Okay. Right. So Dr. Stephen Karuba is a current fellow of cornea, external disease, and refractive surgery at Duke Eye Center in Durham, North Carolina. He completed his medical degree at Georgetown University and his residency training at NYU Langone Health in Manhattan. And so we welcome that Dr. Karuba. Please go right ahead.
All right. All right. Hi, everyone. It's nice to be here. Thank you very much for the opportunity to talk on this topic today, discussing the role of primary care providers in preventing blindness, specifically from glaucoma. So I'd like to start with this particular study. It's put out by the U.S. Preventive Services Task Force, which is an independent volunteer panel of national experts in disease prevention. And they released the following statement after a systematic review. They said the evidence on the accuracy of screening tests for glaucoma, especially in primary care settings, and the benefits of screening or treatment to delay or prevent visual impairment or improve the quality of life is inadequate. Therefore, the U.S. Preventive Task Force is unable to determine the balance of benefits and harms of screening for glaucoma in asymptomatic adults. So it would seem based on this that I should just end my presentation here, because it seems there's no obvious benefit to screening for glaucoma in primary care settings. But if you read the report, it actually confounds the word screening and diagnosis. In fact, they go on to discuss the impracticalities of diagnosing glaucoma in the primary care setting. And it's true, in order to accurately detect glaucoma, true diagnosis of glaucoma, you need things like a careful assessment of the optic nerve, serial intraocular pressure readings, visual field testing, sometimes optic nerve testing, and so on. And even then, months later, we're sometimes scratching our head saying, is this truly glaucoma or is this something else? And so the diagnostic tests that we do in an ophthalmologist's office many times just aren't practical for, a community setting or general medical office. So, yes, accurately diagnosing glaucoma in a primary care setting is a difficult task and many times not feasible. But that doesn't get you off the hook. A few facts. We know presently 72% of individuals with glaucoma will remain undiagnosed globally. So in many ways, glaucoma is a silent epidemic. The estimated number of glaucoma patients worldwide by 2040 will be around 140 million. And of those, 67 million are estimated to go undetected. Undiagnosed glaucoma can lead to permanent consequences and have significant effects on activities of daily living, things like mobility issues, difficulty driving, falls, poor reading ability, depression, and ultimately blindness. So the only way we can make any progress on this front is to work to help reduce global blindness together, and we can. So I was thinking about what in particular the primary care physician is uniquely poised to do. And, in diagnosing or rather in screening for glaucoma and talking to patients about this. And so I came up with a list of things that kind of explain why primary care providers should be allies for this cause. So for one, for many, the primary care provider is the first or only point of contact within the healthcare system. So to the average person, navigating the healthcare is complex. Many individuals may not schedule regular eye exams with an eye provider. They may not be inclined to do so unless recommended by a primary doctor. These individuals look to you for next steps. You may be the first person to hear a particular chief complaint related to the eyes. And given the magnitude of undiagnosed glaucoma in the world, you're sure to be encountering patients who would benefit from a referral for a more detailed exam or subspecialty appointment. Number two, primary care providers have established strong longitudinal therapeutic alliances with their patients, and patients don't always volunteer information. Many, symptoms they think are not worth mentioning. And it's rare that a patient comes into your office and says, "Oh, I think I'm developing glaucoma." There may be subtle signs or symptoms that only present on a more detailed conversation. And I'm sure, as a primary care provider, you discuss all sorts of things. And so there's a bond of trust and open communication. And those conditions allow for patients to feel comfortable to bring up their concerns. Number three, primary care providers are keen listeners. You have an idea of what's normal and what's unusual for a particular patient on a very individualized level. And you take the time to listen to their concerns, which is key. And primary care providers are also able to ascertain a detailed understanding of patient and family medical history. And that's crucial. Let's face it, you all take a much better history than we do. You ask detailed information about onset, duration, provocation, quality, severity of a particular symptom. And you know the family history well. You may have even taken care of some family members of your patient too. You have a broad knowledge base, and basically you're able to understand risk factors which patients are often unaware of. So the interplay of things like age, race, family history, other comorbidities that might put patients at risk. And you are most importantly have experience managing chronic disease. You understand the importance of medication adherence and follow-up appointments. You can convey that well to your patient and be good educators for them. And lastly, you're natural coordinators of holistic patient care. And so you can help coordinate care of the whole person, and recognize and address the barriers to care. So if glaucoma diagnosis is affecting a patient's mood, their mobility, their finances, or if it's affected by social determinants of health, you know who to talk to get them the right resources to improve their quality of life, whether it's occupational therapy, social work, psychiatry, or ophthalmology. So this particular study is from 2015. It's a survey study of 82 primary care physicians, and they were asked basically to rate their agreement with the following statements describing their role in glaucoma care. And if you look here, about 99% of primary care physicians in this survey agreed that they had a role in early detection of glaucoma, specifically asking older patients about family history, identifying those at high risk, and referring them for an eye exam. 85% agreed that it was within their role to explain the proper use of eye drops to glaucoma patients. 93% thought it was consistent with their role to discuss the importance of adherence and to treatment and to follow-up. And 91% agreed that they should maintain good relationships with ophthalmologists in their community. But if we look here at the next column, basically saying how many of these providers actually follow those practices and behave accordingly in their practice, you can see a much different story. So only 30% of providers said they were active participants in early detection of glaucoma. 35% said they were active in the medical management of glaucoma. Only 64% said they helped promote treatment adherence to glaucoma treatments. And about 56% said they actually actively helped coordinate eye care. So clearly there's a discrepancy here that's worth noting. And when surveyed on what barriers to glaucoma care were present, providers described things like lack of time, lack of knowledge on the risk factors, lack of ability to do a diagnostic evaluation, and lack of knowledge about treatment options and recommended follow-up schedule and things like that. So what can you do? What are some practical things that you can do to actively be involved with a patient's glaucoma care? And so I have a few things I want to talk about. The first is taking a thorough history. So I like to think about glaucoma history or asking a patient about glaucoma in three separate buckets. First is the eye bucket, then the systemic bucket, and third, the family bucket. So bucket one, ask about subjective vision changes, especially in patients over 40. Are they experiencing any eye pain, redness, transient visual obscurations? That might be a sign of closed angle glaucoma. Unfortunately, there aren't too many warning signs for primary open angle glaucoma until disease has progressed and is beginning to affect vision. Patients with more advanced disease will describe a fogginess or a cloudiness, loss of peripheral vision. but definitely ask if they are established with an eye provider. Have they ever had a dilated eye exam? When was their last dilated exam? Have they ever been told they've had a high eye pressure? Definitely document any known eye conditions, any prior eye surgeries or injuries. Multiple complex prior eye surgeries or eye injuries are a risk factor for glaucoma. Many patients have a known history of glaucoma surgery or laser, and they may identify that for you. Secondly, in the second bucket here, I like to ask about symptoms of close proximity. Things like severe recurrent unilateral headaches can be a sign of intermittent angle closure, head or periorbital pressure is important to ask about. And also document any comorbid conditions. We know that glaucoma is often comorbid with things like hypertension, diabetes, obesity, dyslipidemia. So definitely document those things. Are they a steroid user? Ask about current medications. Both topical and systemic steroids can have an effect. There's definitely a known association between those and intraocular pressure. And then lifestyle factors, especially smoking, which has a causal relationship. For patients with a known diagnosis of glaucoma or advanced disease, ask about quality of life. Are they experiencing new difficulties with activities of daily living, reading, driving, things like that? That could be a sign that things are progressing. And then in the third bucket, ask about family history. A first-degree relative who has open-angle glaucoma conveys about a 4 times higher risk to the patient of developing glaucoma. When was that family member diagnosed? How were they treated? How is their vision presently? What's their ancestry? African ancestry confers about a 6 to 8 times more likelihood of developing glaucoma. Hispanics as well. Asians have a higher risk of angle closure glaucoma. So these are all important things to note. Number 2, assess the risk factors. So this is a chart of the relative risk for different factors related to glaucoma. So for instance, age confers a 2 times higher risk over the age of 40, African ethnicity a 4 times higher risk, family history 2 to 4 times depending upon what degree relative it is, a low diastolic blood pressure. So low blood pressure can cause hypoperfusion to the optic nerve. So chronically low blood pressure is a risk. Patients who come in with cold hands and feet and a low body mass index, that's something to be aware of. If you have access to intraocular pressure readings, tonometry, higher eye pressure, of course, has a correlation and an increased relative risk, and nearsightedness as well. You might consider incorporating a question-based risk assessment. So, something like similar that you would do for breast cancer or depression. Blindness is definitely a worthwhile cause when it comes to incorporating preventative questionnaires. So things like, have you had a detailed eye exam more than getting your glasses just measured? Do you have a blood relative who had glaucoma or blindness? Were you told in the past that you've had glaucoma but stopped going for treatment? A positive answer to one of those things might trigger a referral to an eye provider. Number 3, understand the clinical signs. If you're a provider who feels comfortable using a direct ophthalmoscope or has a means to obtain fundus photos, take a look at the optic nerve, see if their cup to disc ratio is enlarged. If they have hemorrhages around the disc, those things can certainly put a patient in the glaucoma suspect category. Basic visual field testing can be done by asking the patient to cover one eye and getting a sense for their gross field with your fingers, move from the periphery to more centrally. I think the oblique pen light test was talked about yesterday. So shining a pen light across the eye perpendicular will present a completely illuminated iris if there's no concern for a closed angle. If there's a shadow that forms across the iris, then there is concern potentially for a narrower closed angle. And lastly, if you feel comfortable checking the pupils and looking for an afferent pupillary defect, that's another sign as well of advanced disease. Number 4, escalate care. So these are some general guidelines for when to refer to an eye provider. It's important to maintain relationships with local eye care providers. If there's any concern for an acute glaucoma process, things like unrelenting eye pain, decreased vision with eye pain, redness, fixed non-reactive pupil, that's definitely a reason to send a patient to the emergency room or immediately to a local provider, given a concern for angle closure. If there is a risk for glaucoma, for instance, a strong family history, over 60 with vision changes, a prior eye injury, or chronic steroid use with vision changes. Those are some indications to refer to an eye provider, within a few months. You don't want to wait too long. Fortunately, glaucoma is it's chronic, and so it rarely causes damage in days to weeks, but more on the span of years. So the patient sometimes doesn't need to be seen, the next day, but as long as they get on the radar. And then patients over 40 without a recent eye exam should be seen non-urgently for a baseline. That's based on the guidance of the American Academy of Ophthalmology. Some special situations, patients who are monocular, who have complete vision loss in one eye, are particularly vulnerable to complete blindness. And so you want to maintain special attention to them. Any concern for glaucoma should be promptly referred. For patients who may have had a prior diagnosis of glaucoma or were treated for glaucoma, but were then lost to follow-up, suggesting to reestablish care or referring to reestablish care can really be the difference between seeing and not. And then patients who have a known diagnosis of glaucoma, but are now developing new quality of life issues, vision changes, that's a sign that things could be getting worse. And so you want to refer those patients as well. And lastly, not everything is glaucoma. There are other ocular conditions that can cause similar symptoms, things like cataract, diabetic changes. You want to consider those things in the right patient too. And number 5, promote adherence. So make sure the patient understands that even though you're not an ocular subspecialist, that you're an ally in their eye health. Check in with them on how things are going. Ask if there's any subjective changes. It's helpful to confirm their drop regimen. A lot of these patients are on eye drops kind of indefinitely, and so you want to make sure that the prescription or the drop regimen that they're using, that they're articulating, kind of matches what's on their prescription or what's on their recent ophthalmology note. You can provide refills if appropriate as well, if they're running out of a medicine that they're using for long term. Assess the barriers to adhering to pharmacotherapy. Are the patients having side effects from the drops? Is there burning? Is there itching? Is there blurring? Are they cost prohibitive? Let us know, and we can prescribe alternatives. And also, are they using their drops correctly? Many patients do all sorts of things with their eye drops except actually get them in their eyes. And so you can ask a patient to demonstrate how they administer them. Do they need a shorter refill interval, maybe? So definitely also stress compliance. Make sure patients understand the natural history of glaucoma and its tendency to progress if left untreated, the risks of noncompliance. If the drops are too much of a burden, we have other techniques too, things like laser, minimally invasive surgery that we can do to help try to reduce the drop burden. So definitely let us know about those barriers also. And then are there factors that are affecting patients getting to their appointments or picking up their meds? What can you do to help? Let us know. Would a referral to social work be appropriate or something like that as well? And number 6, maintain your knowledge base. So attend meetings and seminars, kind of what you guys are doing right now. Spread the word about glaucoma and chronic eye disease and help others and help your colleagues recognize risk factors. Familiarize yourself with the American Academy of Ophthalmology's preferred practice guidelines. Keep track of the patients you send to ophthalmologists and optometrists. Was there a real concern for glaucoma, or was this just a cataract or something like that? That can help kind of fine tune your assessments. And unfortunately, most medical schools and residencies provide very little insight into the world of ophthalmology. So sometimes this takes a bit of independent learning and reading and being diligent and learning more about this area of medicine. So in summary, glaucoma is a chronic, often silent disease. It's largely underdiagnosed and can have lasting implications. Much like other chronic diseases, it requires vigilance to recognize, diagnose, and treat it. The primary care provider has an important role in recognizing those at risk for developing glaucoma and referring when a concern arises. They play a crucial role in bridging the gap between specialist appointments, ensuring patients are appropriately followed and are following their treatment regimens, and preventing them from being lost to care. So definitely don't be shy about phoning a friend. We are here to help. We much rather see a patient you're concerned about and rule out the diagnosis of glaucoma than see them much later having flown under the radar when not much can be done about it. So together, we can work together to prevent blindness. Thank you.
Thank you. And Dr. Karuba, you have inspired, enlightened, and just motivated me. And I'm sure all your listeners to really work with you with ophthalmologists for the care of patients. And can I tell you, often patients come complaining that the ophthalmologist doesn't understand. And I know I feel at a loss sometimes because I don't know what you're doing. And so it's so good for us to just take up the phone or email or whatever to help the patient understand, what's happening in a situation which is anxiety forming for them. So we really appreciate the advice you have given, and we're going to take it up. Thank you so very much, and please stay for. I'm sure there will be questions at the end. So now we're going to have our sponsors, and that's Indus Pharma. And I see Jordan is ready for us, right, Jordan? Can you go ahead, Sam? I thought I saw Jordan turn on his camera just now. Yes, welcome back, Jordan. Please go ahead with your 5-minute presentation.
Yes. Good evening, everyone. I'm just going to begin sharing my screen. All right. Can you just confirm that you're seeing the screen?
We're not. Sam probably needs some help. We're not seeing his screen.
Yeah, sorry about that. One moment. There you go, Jordan. It's up now.
Okay, great. Thank you. Right. So good evening, everyone. I'm Jordan Fourie, and I'll just be doing a short presentation on a few of the product offerings that we have at BioPress Pharmaceuticals that will go a far way in helping patients who have issues with glaucoma. So I'm sure you will find these products to be very, very helpful to your patients. Right? The 4 products that we'll be focusing on are Travoct, Timolok, Travotim, and Ocuvol. Right, so Travoct is of course our Travoprost, and as you know, Travoprost is a synthetic prostaglandin, and as you know, prostaglandins are compounds that are obtained by chemical synthesis, and of course are derivatives of naturally occurring prostaglandins. And as such, as you know, prostaglandins are one of a number of hormone-like substances that participate in a wide range of body functions that include the contraction and relaxation of smooth muscles, and of course the dilation, constriction, and the control of blood pressure. Right? Travoct is indicated to be used in patients who have is used to decrease elevated intraocular pressure, that in patients with ocular hypertension and patients with open angle glaucoma. Travoct, the dosage for Travoct is 1 drop into the affected eye once daily in the evening. And there is also a cost benefit associated with Travoct, as Travact is available on NHF and JADEP for patients who have an NHF and a JADEP card. But outside of that, each 3 ml bottle would cost the patients around $2,200, right? So very affordable for your patients. Timolol is also another product that we have, which is timolol maleate, right? And the Timolol eye drop contains a non-selective beta-adrenergic receptor blocking agent, and it is indicated for elevated intraocular pressure in patients with open-angle glaucoma and ocular hypertension. The dosage for the Timolol is to instill 1 drop into the affected eye twice daily. Timolol is also available on NHF and a cost of $580 per bottle, per vial, right? Caution should be exhibited in patients who are sensitive to timolol maleate. Also, it is contraindicated in patients who have overt cardiac failure or cardiogenic shock, right, or 2nd or 3rd degree atrioventricular block. Travatin is a combination of travoprost and timolol maleate, right? So the combination is very effective as it contains both the prostaglandin, the travoprost, and also the beta blocker, which is timolol maleate. These 2 drugs help to decrease raised pressure within the eye. They work in different ways to produce a combined effect, which is greater than either medicine produces on its own, right? So very effective in patients who have glaucoma, right? And it is used to decrease elevated intraocular pressure in patients with ocular hypertension and open angle glaucoma who are insufficiently responsive to a topical beta blocker or a prostaglandin analogs. Travatin, its doses is to instill 1 drop into the affected eye once daily in the morning or evening. It should be noted that the Travatin must be administered at the same time each day, right? Travatin is also covered under NHF, and so all patients with an NHF card will benefit from the subsidy, right? Also, if you have patients who are in the drug serve, the public facilities, they can access Travatin through drug serve pharmacies as well. Next, we have Ocuvalt, which is our diclofenac sodium, right? So Ocuvalt contains diclofenac sodium, which demonstrates both anti-inflammatory and analgesic properties, right? And it inhibits the enzyme cyclooxygenase, which is essential in the biosynthesis of prostaglandins. Ocuvalt is indicated for the treatment of post-operative inflammation, right? It is also very effective in the temporary relief of pain and photophobia, and it also is effective in ocular inflammatory conditions like iritis, chronic conjunctivitis, right? And it should be noted that Ocuvalt is now the only diclofenac sodium eye drops available on the market for patients, right? So very important. So Ocuvalt, the dosage for adults, 24 hours after surgery, instill 1 drop into the affected eye 4 times daily. And for inflammatory conditions, patients can instill 1 drop 4 times daily until symptoms have been resolved. Each bottle of OcuVolt cost the patients around $1,579, right? So very affordable. Right. So what you're looking at now is just some of the other eye drops that we have available. Ciprotop, ciprofloxacin, iWet, which is of course the lubricating eye drops. We have Ocularge for allergies and Ocured for redness, inflammation, right? And so those are some of the others that we have. We also have Tobropt and Tobropt D, which is tobramycin, and Tobropt D, which is of course tobramycin along with dexamethasone. Right, so that's basically it for us. We do thank you for having us. Looking forward to your support with these eye drops for your patients. If you have any questions, also if you want to place any orders for any of these products, my contact information is on the screen. So thanks again, everyone.
Thank you very much, Jordan, and for giving us those useful information for us here in Jamaica. So moving right along, I know Dr. Hazem Musa is with us, and so we're going to be looking at his presentation on glaucoma and quality of life, addressing the psychological impact, coping strategies, and patient-centered care. So we're really interested in this. He is a second-year resident at the Duke Eye Center, earned his medical degree from the American University of Beirut School of Medicine, and he also, before residency, dedicated time to doing research in ocular immunology and ocular surface diseases at Duke. So we look forward to his presentation. Dr. Musa, thank you.
Thank you so much for the introduction. I'm Hazem. I'm one of the second-year residents at Duke University at the Eye Center. And today, as we mentioned, we'll be talking about glaucoma and quality of life, mainly focusing on the psychological impact that this disease will have on the patients. And as providers, as primary care providers and ophthalmologists, the ability to identify the impact it's having on these patients and provide coping strategies and providing more of a patient-centered approach to dealing with the condition, not just the vision loss part of it, but altogether as a disease impacting multiple factors of life. And just a brief overview again about glaucoma. I know other talks have discussed this before me. It's a group of eye conditions that damage the optic nerve. And the thing is that they do this rather silently. And the key word is they do it silently. The patients that are experiencing it do not realize it's happening until it's too late or until the vision loss is affecting the main part of their vision. And once that vision's gone, it's gone for good. And there's currently no treatments that will regain that vision that is lost. It is a global problem. It affects millions of people worldwide, and it is a leading cause of blindness across the globe, especially in patients over 60 years old. And that is relevant because these patients have other comorbidities they're dealing with, and vision loss on top of that is a major impact on their quality of life. It doesn't, and as Dr. Williams mentioned in his talk, there's a variety of different types of glaucoma, some of which can even affect patients at a much younger age. And this causes a lot of social and mainly social impact on those patients' lives, especially if they're at school or if they are starting to get their career underway. It is a major burden on them progressing or along with or being close to people around them. So it impacts more than just those patients' vision. Eventually, as the disease progresses, it leads to loss of peripheral vision and closing in of the vision to what we call tunnel vision, in which patients mainly can only see centrally and no longer have the the peripheral vision that they can rely on for multiple things. Now, what are the factors in glaucoma that impact the quality of life? Let's talk about the different parts that this disease can cause a burden on these patients' lives. First, in terms of comorbidities, we mentioned that it predominantly affects patients above 60 years old, and those patients often have other conditions such as diabetes, hypertension, arthritis. They have balance issues. They can barely get from point A to point B by themselves because of these different comorbidities. And then suddenly their peripheral vision is not as good. This impacts them further, so they can no longer be as mobile, they can no longer do the things they want to do, but also raises risks of potentially falling, injuring themselves, which at that age and with such comorbidities could be debilitating, if not even life-threatening. And so in that sense, it is a major impact on quality of life. The other thing is the duration of disease. It is a slow, progressive, long process that is pretty much following them for the rest of their lives. And it's something that needs a lot of commitment, a lot of dedication to deal with day to day across those long years. And so this continues to impact them day to day for the rest of their lives. And that is a big burden on these patients to deal with. The other thing is, as Dr. Karuba before us mentioned, treatment-related factors. These patients are now committed to having to see an ophthalmologist multiple times a year, oftentimes every 3 months, every 3 to 4 months. And this, in patients that are over 60 years old, adds to their burden of having to see the doctor multiple times for their different comorbidities. And not only that, they now have to take it could be 1 drop, it could be up to 5 drops a day, which could be very annoying for these patients. And it's a new commitment they have to add to their day-to-day life, and it can have a lot of implications on the quality of their life, just in terms of how they plan their day, in terms of things they need to keep with them as they go, and those different aspects. And these medications, especially in the United States, do come in with preservatives for the bottles, and those preservatives tend to have a lot of treatment-related side effects. They can burn the eye, and they can cause a lot of dry eye, which can be burning on a day-to-day basis, which is very debilitating and very annoying for these patients to have to deal with. In addition, sometimes it can cause lid abnormalities because they have to pull their lid down every day to put that eye drop in, and eventually that ends up leading to see another eye doctor, which ends up leading to more treatments and more procedures on these patients, which is a big burden. And the main thing we want to stress on is the psychological burden, which is often ignored. Living with this chronic progressive disease takes its toll. And anxiety, they're always anxious about the unknown of what's to come in terms of losing their vision. They know that the vision they already lost will not come back, and that this will continue to progress, sometimes even despite perfect compliance and perfect follow-up and perfect monitoring of the disease. And this can lead to a lot of frustration on these patients navigating daily challenges, often leading to depression, which eventually leads to reduced compliance, which eventually leads to even a worse outcome, and so forth. So this leads to sort of a vicious cycle, as you can see here in this diagram, where this psychological impact sort of adds onto itself to cause even more damage. As we mentioned, the vision loss keeps them from doing different things that they want to do. Like if you can imagine having to live with the constant fear that you have lost some of your vision and that you will continue to do that. That fear alone is very heavy on these patients. And now add to that a daily pressure of you have to take these drops now, you have to see this doctor at this point, and you can't delay that visit. You have to commit to making it to that appointment. Sometimes you might need a surgery that you will have to deal with the follow-up from. This all together is very overwhelming to patients and can lead to a lot of anxiety. And this vision loss and these commitments that they have to make often causes these patients to lose their independence or their ability to do the things they want to do otherwise. As Dr. Karuba mentioned, sometimes driving, reading, being able to do their hobbies, sometimes even recognizing faces becomes more difficult. And this leads to frustration. This leads to their inability to rely on themselves to do the things they want to do. They always have to have someone with them, and that leads to even more frustration. And all that together leads to mental health issues, including depression, which can exacerbate or worsen compliance, which then can exacerbate the vision loss. So it sort of leads them into this sort of social isolation because they are unable to go out and meet their friends, go out and do the hobbies they want to do because of the impact of the vision. So it's not just about the vision loss, it's about what that vision loss portrays to those patients that us as providers, primary care or ophthalmologists need to always keep in mind. A lot of times in these patients, compliance is a major issue, and it's important to understand where that lack of compliance comes from, not just judge them or show them that they're doing the wrong thing. It's more about understanding what's causing them to not be able to commit to the different treatment modalities that they need to. And oftentimes depression is a major factor in why that is happening. So how do we help these patients cope with the emotional and psychological weight of glaucoma? It starts with connecting with the patient and providing them with knowledge and support about the condition. First, education and awareness. As we discussed, the fear of the unknown is a big driver of the anxiety that these patients face. But when they truly understand the condition, how it progresses, what the treatments are doing, and what they can control in that disease, and that's the main thing, is to give them some control about the proceedings. It eases the anxiety, which eventually eases the progress that we showed earlier that leads to depression. A lot of times it's difficult to convince these patients to take this eye drop 3 times a day when it's such a silent disease that they're not noticing that this eye drop is helping them. And so educating them on the progression of this disease is very important so that they understand the importance of taking that eye drop and are working with the provider to manage this condition. But knowledge alone is not enough. They need to have people around them, whether it's family, friends, or peer groups that create a safety net, that keep sharing among each other the importance of compliance and importance of treating this disease. And this sort of is provides a motivator to continue doing that. If they don't have someone in their family or friends that can support them close by, a lot of times we can recommend online groups. There's a lot of groups or patients that tell me that they found groups on Facebook that really help them connect with other patients with these conditions. And they can talk to each other and see what helped each of them and share those modalities to improve outcomes among themselves. And in patients with deeper psychological distress from this condition that have progressed to the depression phase, a lot of times it's important to recognize that. And that could be the ophthalmologist, that could be the primary care doctor, to understand that this patient needs therapy beyond just support and encouragement. They need to be referred to a specialist. Sometimes a cognitive behavioral therapy and counseling can help ease the depression and the anxiety related to glaucoma and help these patients cope with that and eventually improve quality of life. And as Dr. Bletcher touched upon, mindfulness and relaxation exercises, as well as just physical exercise, can be a major component in improving those patients' quality of life and their mental health altogether. So it's like a 2-in-1 hit. As healthcare providers, we play a crucial role in improving the outcome in the quality of life. This goes beyond just the visual field and the pressure readings and the medication prescription. It's about developing a human connection with the patients, showcasing empathy and understanding of where it all started. Patients are often having this fear, this frustration of the uncertainty, and simply acknowledging that is very important. And as we mentioned, collaborative approach, identifying patients that need different specialists, including mental health professionals, to address the underlying anxiety and depression that can be involved in these patients could be very beneficial. In addition, sometimes we can offer rehabilitation specialists that help them cope with the vision loss or the vision impairment that they are dealing with, and provide them sometimes with assisted devices or assisted exercises that help them navigate or still be able to do the hobbies they want to do, even with the vision loss they encounter. And of course, always keeping in mind that these patients are prone to developing psychological despair, and continuously monitoring it during the different visits with different providers they follow with is important to identify these problems early on. And, these are some of the things we touched upon: psychological screening at different visits, educating them about the different about what the drops and what the treatment modalities are doing, helps them work with us as a team to treat this disease, and social encouragement and participating with different groups and engaging with different people that suffer with the same issue, as well as resources in terms of the rehabilitation resources and the mental health specialists we discussed. Oftentimes, these patients come with family members to clinic visits. Sometimes it's because their vision is impaired and they need someone to help them make their way to the clinic. And when we see those family members, it's important to engage with them as well, because the family members or the support system these patients have could be a very good element to incorporate into the treatment plan. When the family member understands the importance of the drops and the treatment regimen and the emotional and psychological distress that this disease can cause, they can also be part of the treatment process and part of the support system that this patient needs, and encourage compliance with the medications and the treatments, as well as be able to identify the alarm signs of psychological distress, for which they can also seek earlier care and come back to be assessed sooner so that we can identify these earlier. A lot of promising developments recently in the technology world that is not only changing how we treat glaucoma or how we diagnose glaucoma, but it's also changing how we support these patients emotionally and improve their quality of life. And there's a lot of technological tools that are at our disposal at the moment to deal with the disease itself, as well as the mental and quality of life comorbidities that this disease causes. Digital mental health tools, there's a growing number of easily accessible, for example, mobile apps that these patients can do. They can help them manage stress and anxiety, depression. Some of them can guide the meditation or mental health exercises that these patients can benefit from, give them reminders to do so, walk them through it as well if they are unaware of how to do it. And this helps strengthen the mental health aspect that this disease suffers from. Another key component that could be very beneficial in these patients, which can lower the burden of having to come to different clinic visits and the transportation and taking time out of their day to wait in a doctor's clinic. Telemedicine is another aspect that could be a future game changer. There's a lot of developments in terms of doing the testing that we would do in clinic that we could potentially do at home, such as visual fields and OC and the ocular and the testing of the optic nerve. These could be a game changer in the follow-up arrangements of these patients. They no longer have to come to a clinic, which could sometimes be very far away from their home every few months. This could potentially space out the need to come into the clinic itself. As well as the telemedicine has been a growing field in psychology or in psychological consultations. A lot of patients no longer have to drive to see the psychologist. A lot of these are being done virtually, and this could also lessen the burden of the treatment plan altogether. In addition, we talked a bit about rehabilitation aids and exercises they can do. There's also a lot of visual aids, which I believe Dr. Allen will discuss further in the upcoming lecture. These target more the visual aspect of this disease, and by doing so, improves the quality of life, allows them to do the hobbies they want to do, potentially, and from there could also act on the primary cause of the anxiety and the depression that these patients are suffering from. Just a quick study I wanted to share, the improved glaucoma medication adherence in a randomized control trial. This was done by some of our faculty members at Duke Eye Center, Dr. Mir and Dr. Rosal. And this evaluated a multi-phased intervention to improve and tested glaucoma medication adherence in a cohort of patients at the Durham Veteran Affairs. These patients diagnosed with glaucoma and are on topical medications were enrolled in the study, and they tested adherence in those patients that underwent the intervention, which in this case included education and strategies to overcome individual adherence barriers, smart drop reminders, printed schedules, and companion involvement when applicable. So this intervention touches a lot upon the stuff we already talked about, including educating the patients, having a support system around them, and technological aids such as smart bottle reminders. And we wanted to see, and the authors wanted to see how that impacted adherence to the medication. And it did show that patients that underwent the intervention, which included a lot of the holistic approach and modalities, did have an 85% adherence versus 62% in those that did not have the intervention. And this was a significant improvement in those outcomes, suggesting that a more comprehensive approach that relies on patient education can rely on technological aids, as well as ensuring that these patients have a support system, could be drastically beneficial in promoting adherence and promoting treatment, which would potentially entail promoting treatment outcomes in these patients. So key takeaway is that glaucoma is not only affecting the vision, it is affecting these patients psychologically and their quality of life. And it's important from our standpoint to identify these, because not only is it a great way to improve these patients' quality of life, it's a great way to improve their compliance and treatment outcomes in these patients. Thank you.
So much, Dr. Moose. This was very enlightening, very encouraging. I see the patient I just saw 2-3 weeks ago who is almost blind, holding on to his wife to come into the room, blind from glaucoma. And as his primary care provider, he was seeking some help, some answers. And so your talk was very relevant. Dr. McIntosh, Maynard McIntosh, will help us a little later after the final speaker with some of the Jamaican perspectives, especially with regards to resources for persons who are at the pretty much final stages or near final stages. So we'll bring him in. Thank you for your excellent timing as well. So please hang on. We do have a lot of questions, I'm sure. So we're going to go on to our next speaker, and this is our only female for the night, Dr. Ariana Allen, also consultant ophthalmologist. Welcome. She'll be speaking on artificial intelligence and glaucoma, telemedicine in ophthalmology. And we're really going to look forward to that. Let me just get my, okay, where are you? Okay, here we are. Right, so Dr. Allen is a first-year ophthalmology resident at the Duke Eye Center, where she also completed her medical education. Her primary research focus during medical school was on OCTA, and she'll have to tell me what that is, as a biomarker for frontotemporal dementia. And that sounds very interesting. I suppose that's CT of the eye, ocular, CT of the eye, how it could be used as a biomarker for frontotemporal dementia. Now that is really exciting. But we're looking forward to her to talk about the role of artificial intelligence and telemedicine in glaucoma care. Please go ahead, Dr. Ariana.
Thank you so much. All right, good evening, everyone. I'm Ariana. I'm a first-year ophthalmology resident at Duke. And today I'll be talking about how artificial intelligence and telemedicine are transforming the early detection and treatment of eye diseases. So with the increasing burden of vision-threatening conditions like diabetic retinopathy, glaucoma, and age-related macular degeneration, early diagnosis and intervention are more crucial than ever. And artificial intelligence and telemedicine offer groundbreaking solutions that can improve efficiency, accessibility, and patient outcomes in eye care. So in this presentation, we'll explore the current landscape, real-world applications, and future directions of these technologies in eye care. And so we can start with our 2 practice test questions. Question 1, in the context of telemedicine and ophthalmology, what does the store and forward model entail? A, real-time video consultations between patients and ophthalmologists. B, capturing patient data and transmitting it to a specialist for later evaluation. C, remote monitoring of intraocular pressure. And D, automated AI-driven diagnosis without human oversight. And question 2. Which of the following is a significant ethical concern when implementing artificial intelligence in ophthalmology? A, enhancing image resolution in retinal scans. B, reducing the workload of ophthalmologists. C, bias in AI models due to non-representative training data. Or D, increasing the speed of patient consultations. We'll revisit these questions after the presentation to see how your answers align with the content we discuss. And so today we'll talk about the burden of eye disease, AI in ophthalmology, telemedicine, the challenges and ethics associated with these topics, and future trends. So vision loss is a major global health issue affecting over 2.2 billion people worldwide, according to the WHO 2019 World Report. And many of these cases are due to preventable or treatable conditions like diabetic retinopathy, glaucoma, and age-related macular degeneration, or AMD. And one of the biggest challenges, as mentioned, is that these diseases often develop silently, without symptoms in the early stages. And by the time a patient notices vision loss, irreversible damage may have already occurred. This takes and makes early screening and diagnosis essential, but many people, especially in rural or underserved areas, don't have easy access to eye care. And this is where artificial intelligence and telemedicine can make a significant impact by helping us detect diseases earlier and helping us reach more patients. So artificial intelligence is defined as the theory and the development of computer systems able to perform tasks that normally require human intelligence. And it encompasses many different technologies. In particular, machine learning is defined as the capacity of a computer to learn from experience, and it involves algorithms that learn from data to make informed predictions. Neural networks are computer systems modeled on the human brain and nervous system, in that the software is built as a network of neurons communicating with each other with multiple inputs and outputs. And then within this bucket are deep learning algorithms, which use neural networks to analyze complex patterns. And this version of machine learning algorithm is especially useful for medical image analysis. So AI is already being used in medicine with examples like Abridge as an artificial intelligence scribe for writing notes, and ChatGPT and Open Evidence AI that help solve diagnostic questions. And AI has shown incredible potential in ophthalmology, particularly in the analysis of retinal images. So deep learning algorithms can detect abnormalities in retinal images and can be taught to detect diseases like diabetic retinopathy and age-related macular degeneration with accuracy that is comparable to ophthalmologists. At Duke, there's several teams using AI in their ongoing research. Some examples are Dr. Medeiros' research team. They trained an AI model to predict retinal thickness measurements using fundus photographs, which are another version of photos of the back of the eye. And they have since developed several different AI algorithms to help detect glaucoma. Similarly, Dr. Ladd in Retina is researching applications of AI to improve the diagnosis and treatment of age-related macular degeneration. And then in the larger scheme of things, an increasing number of AI and machine learning tools have been cleared by the FDA, including but not limited to Luminetics, which was formerly called IDXDR. This is an autonomous AI system that can analyze a fundus photo for diabetic retinopathy and determine with high sensitivity and specificity whether a patient needs a referral to an ophthalmologist. Similarly, IED, it's a diagnostic screening technology, also an autonomous AI that diagnoses referable diabetic retinopathy from retinal images. And then iArt AI is FDA cleared for autonomous detection of more than mild and vision-threatening diabetic retinopathy. The iArt AI is also approved as a screening tool for AMD and glaucomatous optic nerve damage in the European Union. And then iPredict has also been approved as a screening tool for AMD. And it can predict individual risk scores for development of late-stage age-related macular degeneration. And there are many more tools that are at different stages of the regulatory process. However, right now, there are no autonomous AI-enabled systems for glaucoma screening or diagnosis with FDA clearance. There's numerous assistive AI-enabled software tools, however, that are used in commercialized instruments for quantifying these retinal images and visual fields to augment glaucoma research and for clinical practice. And so overall, by automating screening and diagnosis, these AI tools can be used in primary care to increase screening rates and ensure more patients receive timely care while helping to reduce the burden on specialists. Telemedicine has also emerged in recent years as a very important component in extending access to eye care.
Huge.
Especially in remote or underserved areas. One common model is the store and forward technique, where retinal images are captured in primary care or community settings and then sent to ophthalmologists for review. And this approach has been used in large screening programs for diabetic retinopathy and has been shown to be cost effective. Some telemedicine platforms use real-time video consultations, allowing specialists to access patients remotely. And then there's also mobile apps like Peak Vision, which make eye exams more accessible by enabling smartphone-based screenings. Peak Vision is a sort of portable eye exam kit that lets healthcare workers in the community conduct vision screenings to identify people who need to be referred to an ophthalmologist. And overall, studies show that teleophthalmology not only increases screening rates, but also improves early disease detection, ultimately preventing vision loss. Teleeducation is another very important part of telemedicine. There is an Orbis telemedicine platform called CyberSight that has used teleophthalmology to provide access to on-demand ophthalmologist advice for complex cases, provides mentoring of local eye care professionals, and even online education to help build knowledge. There's a CyberSight library, which is a free repository of over 1,000 surgical videos, quizzes, textbooks, and simulation training materials that are available in multiple languages. And the platform also has a CyberSight AI tool that is capable of analyzing fundus photos to detect common eye diseases. And this merges the telehealth aspect with the AI aspect to build a platform to support physicians in rural and low resource settings around the world. This type of convergence of telemedicine and AI allows for a synergistic approach to improve eye care. In this way, AI algorithms can autonomously analyze retinal images obtained via telehealth platforms, which expedites the diagnostic process and allows for more prompt interventions via referral to ophthalmologists. However, despite all these advancements, there are several challenges and ethical concerns to consider. First, AI models can be biased if they're trained on non-representative databases. For example, an AI system that's trained primarily on images from one demographic group may not perform as well on patients from another demographic group, which can lead to misdiagnosis or overlooked conditions. So ensuring diverse and high-quality training data is critical to mitigate this risk. Second, regulatory approval is a major hurdle. AI tools have to go through extensive clinical validation before they can be widely adopted in clinical practice. And the FDA approval process for medical AI is still evolving. And third, data privacy is a significant concern, especially in telemedicine. Patient information has to be securely transmitted and stored to comply with HIPAA and other regulations. But the increasing sophistication of cyber threats requires ongoing investment in advanced security measures to safeguard against data breaches and any unauthorized access. And fourth, while AI can assist with diagnostic accuracy and efficiency, it's imperative that it serves as a tool to support, not replace, clinical judgment. The physician-patient relationship is not replaceable, and it has to remain central to quality care. And while AI and telemedicine have the potential to enhance healthcare delivery, successful implementation in clinical practice is another challenge. With the rapid evolution of AI and telemedicine tools, physicians have to continually update their skills and knowledge. So ongoing education and training are really important to ensure that providers can effectively and ethically use the new technologies in patient care. And other barriers include cost, digital literacy, and development of the infrastructure necessary to use these resources by investing in the necessary hardware and software. So looking ahead, AI and telemedicine are poised to further transform ophthalmology in exciting ways. One promising development is home-based AI screening, where patients can use smartphone-based fundus cameras or home optical coherence tomography devices, that's
Build a
OCT,
facility in
which allow for more ophthalmic imaging to monitor eye health at home. And this could be particularly useful for diabetic or glaucoma patients who require frequent monitoring. We're also seeing the rise in wearable technology, which can potentially enhance the effectiveness of AI-driven tools. There was a study in 2018 that tested a contact lens-based continuous intraocular pressure monitoring device to identify the intraocular pressure parameters associated with primary open-angle glaucoma. And another example is in the form of continuous glucose monitors and insulin pumps in helping to control diabetes and prevent progression of diabetic retinopathy. And of course, AI algorithms play an important role in research. It's expected that AI algorithms will help in identifying new disease biomarkers to help screen for and/or diagnose disease, predict progression, and even recommend personalized treatments in the future. Ongoing clinical trials and interdisciplinary collaboration are going to be key to refine these technologies and ensure that they're safe, effective, and widely available. So in summary, AI and telemedicine are revolutionizing ophthalmology by improving early detection, enhancing access to care, and making eye disease management more efficient. AI-powered screening tools can help detect diseases earlier, reducing the burden on specialists and improving patient outcomes. And telemedicine is expanding access to underserved populations and increasing screening rates. However, there are still challenges to address, including bias in AI models, regulatory hurdles, and data privacy concerns. It's important that we continue to refine these technologies to ensure that they benefit all patients equitably. And as physicians, we have to stay informed about these advancements and embrace new technologies that can enhance the way that we diagnose and treat eye diseases. So now we can revisit our practice questions to assess our understanding after the presentation. And question 1, in the context of telemedicine in ophthalmology, what does the store and forward model entail? A, real-time video consultations between patients and ophthalmologists. B, capturing patient data and transmitting it to a specialist for later evaluation. C, remote monitoring of intraocular pressure. Or D, automated AI-driven diagnosis without human oversight. The answer is B, capturing patient data and transmitting it to a specialist for later evaluation. The store and forward model in teleophthalmology involves collecting patient data like retinal images and then transmitting that data to an ophthalmologist for later review, which allows for increased screening rates, especially in remote or underserved areas, by allowing specialists to access patient data without the need for a simultaneous interaction. Question 2. Which of the following is a significant ethical concern when implementing artificial intelligence in ophthalmology? A, enhancing image resolution in retinal scans. B, reducing the workload of ophthalmologists. C, bias in AI models due to non-representative training data. Or D, increasing the speed of patient consultations. The answer is C, bias in AI models due to non-representative training data. A critical ethical concern in deploying AI within ophthalmology is the potential for bias arising from non-representative training data sets. If AI systems are trained predominantly on data from one specific demographic group, then their diagnostic accuracy may diminish when applied to diverse populations, which can lead to disparities in patient care. All right, that's everything. Thank you all for listening. Here are my references. And now I'll turn it over for discussion and any questions.
Wow. Thank you so much, Ariana, Dr. Ariana Allen. You really have finished us off with a bang, and really see all the congratulations. So we're just going to have a little perspective from Dr. Maynard McIntosh, the Jamaican perspective. And so he has some points. We'll give you just 5 or so minutes because we're right on time, Dr. McIntosh. And so please go ahead and share some perspectives on the Jamaican situation. Thank you.
Okay, can you hear me now?
Yes, we can.
Okay, and I wanted to say a big thank you to Professor Williams and his team from Duke. They really did a marvelous job over the last 2 days. I'm going to touch on 2 things quickly. The points that Ariana made, I'm just going to reiterate them. The fact that in my practice, I've been trying to get my staff and technicians to come on board with telemedicine. Already we use it a lot because we have an EMR, and I think the key to that is if doctors would get an electronic medical record system where we can share information, send you photos, images, videos, and information on patient care, then we can always share this information to treat the patients more holistically. And you can, nothing like seeing the retina for yourself to see what's going on in the back of the eye. And it tells you a lot as a family physician, how the diabetes is affecting the patient's kidneys and brain and other organ systems. And what we do, we also, in real time, send off images, videos, B scans, and so on to our retinal specialist who resides overseas. So a patient will be in my chair and they're having a retinal consult while I'm seeing them. Or I'll be driving on the highway and I am getting images of a patient with their intraocular pressure and their scans, their OCTs, retinal photo. And I can right there in the car make suggestions as to what next to do and inform the nurse when to schedule what procedure and so on. So the telemedicine is alive and well, and ophthalmology really is a field that lends itself to that kind of patient care. It also reduces the burden, the in-office burden, because sometimes patients just don't have the time to spend all the time in the office waiting room and so on. And this gives them some kind of freedom of movement. The other area I'd like to touch on is the effect, the lifestyle effect of a blindness diagnosis in case of glaucoma and other blinding diseases. I did a book chapter some years ago on it, and it is pretty much like a grief reaction. And so a lot of patients, you mentioned the patient coming into you with his wife to discuss his options and so on. Patients tend to go through a grief reaction scenario, which they go through 7 stages. So they get the shock, and they have the denial, and they have the anger, and then they have they try to seek many different second opinions to make sure that it is what it is, and then they eventually come around to accepting, and then they try to change the lifestyle to suit it. Too many of our glaucoma patients still drive. So a lot of times you will send the patients to have their, they're 70, they have to get this special medical exemption for their insurance. And they come in and they're really only seeing 10 degrees or less of field, or they're really maybe blind in one eye or have severely constricted fields or poor visual acuity. And it's glaucoma, and they really are in denial and should not be driving. So it's very important that the ophthalmologist liaise with the family physician on these issues. And that in my practice, I actually wanted to institute a program where the psychologist actually plays a role in grief counseling, because these patients really need grief counseling and counseling in terms of how they adjust to the diagnosis and the whole matter of not seeing as they used to. It's a lot to take in, and Dr. Musa, the doctor who presented on that topic, really hit it when he spoke about the support for caregivers, because the caregivers really are oftentimes forgotten in the scheme of things, and they're the ones who really have the burden of dealing with the patients. The Society for the Blind actually has a lot of programs to support persons with this diagnosis and the ongoing changes that they may have in terms of the education and training and the vocational adjustments that they need to make. They visit the homes, they visit the workplaces, and they visit the communities and social settings, and give a lot of support. So the Society for the Blind is certainly one place to refer patients who have these diagnoses, and they do have field workers who will come out to you and offer a lot of assistance. So that in a nutshell is my...
Yes, thank you so much. I was going to ask you what agencies they could refer to. So thank you. So the Society for the Blind is a group that we could reach out to for those persons who have lost sight. I'm happy for that. Right. All right, I'm sure we have a lot of questions. And so let me see now, where are the questions? I see 8 questions here. So it's open to the panel. One of the attendees asked, what was the most popular might not be the best word, but popular allergy reaction reported? And this must be in regards to the adverse effects of the intraocular pressure, those drops that are being put in. So would anyone like to take that on? What was the most common allergy reaction reported is what I would say.
Probably the most common is red eyes and itching. You see that a lot with bromonidine, but you can see it with some of the others as well. So that's by far the most common one that I see. But those can be quite severe, even leading to like limbal stem cell deficiency and damage to the cornea, and people can have very severe red eyes. The latanoprost can make lighter eyes a little bit darker and make lashes longer. Usually people don't complain about that. Some people actually like the longer eyelashes. But redness and itching for sure, most common allergy.
Thank you, Dr. Williams. Can I say again, I saw a patient who had stopped her medication because of that redness, but fortunately, when she went back to the ophthalmologist, they replaced it with something else, which wasn't so bad.
And sometimes you end up, there are some preservative-free versions. Sometimes it's not the drug itself, but the preservatives in the drug. So I do have patients who are on preservative-free timolol or preservative-free bromonidine or some of those things, and then they don't have the reaction anymore.
Sure.
So that's one option. Occasionally, people are allergic to pretty much everything you put on their eye, and then you have to take surgical approaches.
Yes, I thank you. Gracia Wheatley-Smith asks, what is the best sleeping position to reduce IOP? Any takers?
Okay. Are you hearing me?
Yes, we're hearing you.
Right. I do know that a flat sleeping position is very good for the brain circulation, head and neck circulation. And I advise my patients who, I'm not talking about intraocular pressure now, but certainly from glaucoma to optic atrophy. The flatter you sleep, the better, because patients do report that when they get up, their vision is best. And then it will, fade throughout the day. So I advise them to have naps throughout the day, sleeping flat on just one pillow.
Okay, so
and
a soft pillow
yeah.
and supine, lying on their back.
And of course, there's a matter of sleep apnea. Those who suffer from sleep apnea will tend to, it's associated with progression of glaucomatous optic nerve damage. And so that needs to be taken care of on the, the physician side of things.
Excellent, thank you. Dr. Caroline Slope asked, there's a move to using eye exam as a way of diagnosing Parkinson's disease at an early stage. Any comments on that?
Okay, when I did a neuroprotective strategy chapter, and I do recall in my research finding that Parkinson's and glaucoma, there are similarities in terms of the neurodegeneration that leads to it. And so persons with Parkinson's will have a similar risk profile for glaucoma. So they are actually related from the neurodegenerative side of things.
Oh, okay. So there may be some connection there. Interesting. Anybody else?
Yeah, it seems like you might be able to see thinning of some of the nerve layers in OCT of the retina that could have some correlation to Parkinson's. I'm not sure whether people are actively using that to diagnose Parkinson's, but certainly from a research standpoint, people have seen correlation between OCT findings and Parkinson's disease.
Okay, thanks much. Philip Samuel says, with the trifecta of glaucoma, POAG in parentheses, AMD, and mild cataracts, and on latanosoprost and dorzolamide timolol eye drops, what are the possibilities and expectations of the patient, short and long term? In other words, I think you're saying with, if you have all of these, glaucoma, AMD, cataract, and you're on treatment, what's the expectation for this patient?
Let me start out on that one, but it's always good to address the one that you can obviously control first, which is cataract. So you stay on your drugs to reduce your eye pressure, get proper nutrition with a lot of antioxidants and so on. Remove the cataract, and removing the cataract will allow a person with AMD to actually utilize low vision aids much better, because there are low vision aids available, especially with nowadays technology, to improve their quality of life. And there is treatment for AMD, especially wet AMD, because you can get anti-VEGF injections, and I've used it and have gotten results from it for wet AMD. But yes, there is intervention, and all three must be addressed simultaneously. And of course, the patient counsels through it.
Yeah.
Just a question. Oh, sorry. Go ahead, Dr. Williams.
Yeah, Dr. McIntosh is absolutely 100% correct. Treating the cataract first, that's the thing that you can easily treat. And even the people with severe macular degeneration, you can often improve their peripheral vision and improve their quality of life, even if you're not improving their central vision. And then the other advantage is cataract surgery often reduces intraocular pressure by about 2 or 3 points. And sometimes even more, depending on how large the cataract was. So there's an advantage there. And frequently during cataract surgery, we can do procedures like eye stent or other MIGS procedures to even reduce eye pressure more, and use our micro-invasive glaucoma surgery techniques. So all of that offers opportunities to protect against the things that we're best at treating, which would be cataract first and then glaucoma. And then if it's wet AMD, there are definite treatments, and they're really quite good. I knew Judah Folkman, who discovered those treatments, and it's really quite an amazing set of discoveries, the anti-VEGF drugs. But they can often even restore vision in patients with wet AMD. So so there's a lot that can be done there. The other advantage of removing the cataract early is it gives the retina specialists a clear view, both optically and with the OCT, to get better data as to what's going on in the retina and the nerve.
Thank you very much. Just before we take the next question, can you give us a range when somebody picks up glaucoma, open angle, whatever, at an early stage, let's say at age 50, is there a time, can you say if they're using their drops, how long before they lose their vision completely? Is there a time frame there?
That's a hard one to pin down. I don't have that discussion with patients because I think a positive approach is very important. It reduces stress because stress can actually worsen glaucoma because stress leads to mitochondrial damage and apoptosis, all the things that cascades that can lead to more nerve damage. So I'm usually more encouraging because I'll tell them anecdotes like, oh, I got a patient with 0.9 cup disc ratio, and I've been treating the patient for over 20 years and they're still seeing, because I do have patients that I was treating in the 90s and we're now in 2025 and they still come to the office and they're still seeing. So I give the positive sides of the story. Unless the patient comes to me with end-stage glaucoma, that's a different story. Then you start from where you're at. But certainly, I go to the limb here and tell them, okay, I'm seeing you, I've caught it early enough. I'm not going to let your vision just go like that under my watch. And I do all I can. Sometimes you have to aim for single-digit pressures. You have to introduce lifestyle changes, the right kind of diet, and everything you can early in the game. And the monitoring is very important. But maintaining a positive outlook, I think, is very important.
Yeah, I think there's if you catch somebody with early glaucoma, no visual field defects yet, and at age 50, I think with good follow-up, there's a decent chance that they won't have vision loss enough to affect their quality of life. I mean, they may still, you can't prevent progression in every glaucoma patient, but I think with good treatment and good follow-up, you have a really good chance of preserving vision in a glaucoma patient like that.
That's good news. Thank you so much. Richard Van Turen asks or says, had patient who had trabeculectomy for glaucoma, both eyes, which was successful, was given Combigan for his right eye, which had more accurate scotoma. 10 years later, said the vision was slightly worse in the right eye and may need to change the drops to timolol and netarsudil or acetazolamide. What is your opinion? Just to say, the same patient had cataract surgery operation but developed poor vision due to macular edema, also had epiretinal membrane on the OCT, had PPV, don't know what that is. Question, should OCT be routine prior to any eye operation? So he actually has two questions. Does he need to change that drop to timolol and something? And should OCT be done routinely prior to eye operation?
All right. So it sounds like that patient had the gamut of things done: cataract surgery, trabeculectomy. Sometimes the trabeculectomies in our population fail. They get bleb formation, cyst formation rather, cystic blebs, and sometimes they flat out fail because of the way we scar aggressively. And so constant monitoring definitely is important. The fact the patient had a vitrectomy could help or hinder the control of the glaucoma. But certainly removing epiretinal membranes in the case of macular edema is very critical because you can treat macular edema with anti-VEGF injections, but if there's an epiretinal membrane, it's stubborn, you have to peel the membrane. My reluctance with handling macular edema in severe glaucoma is that every time you inject you increase the intraocular pressure and the nerve goes through some kind of shock. And so, you run a risk there of repeated injections, possibly potentially worsening the glaucoma. I see it that way. And so sometimes I have to do what you call a burp. I maybe let a little of the liquid vitreous out, or in a pseudophakic patient who has had cataract surgery, you may do it from the anterior chamber, just to ensure that you don't have sudden spikes in the intraocular pressure. But in terms of the change, and PPV is parasplantar vitrectomy. You had asked, you were wondering. In terms of the use of drop, I would say just work with anything that can keep the pressures close to single digits, and it may be a combination drop. So rather than switching from brimonidine or alphagan, whichever, to timolol, why not just use combigan, which is a combination of both? So combination drops are a lot in vogue, and there's some good ones coming out now. So you can use 2 eye drops with 4 ingredients to get maximum pressure response. And so the ophthalmologists, of course, will titrate as they go along to achieve this, minimizing side effects and taking care that there are no adverse effects from the use of the drops.
And should OCT be routine?
Yes,
Prior to?
yes, they should have an annual OCT, and certainly OCTs are routine prior to surgical, and should be, because it's important to know what the prognosis for vision outcome is, even for cataract surgery. So if you can see enough, or the scan it's an optical scan, so if there's too much cataract, you won't get an image. But at some point, knowing what the macula is doing is very important in terms of interpreting the vision outcome, because you want to make sure that the macula is good, because that's where the light impacts on the fovea to stimulate vision. And so that's important. Also, if the patient has comorbidities, like if they're diabetic, then certainly regular OCTs of the macula would be important to detect macular edema. And if they're in this case of glaucoma, you can have macular atrophy in glaucoma along with your optic nerve atrophy. So monitoring that is very important, because that's a good predictor of what the vision response would be down the road.
Wow. Any other comments, Dr. Williams?
Yeah, Dr. McIntosh, again, 100% agree with everything you said. In the things that I'll add, one very common mistake I've seen with people treating glaucoma is, instead of adding drops, they switch drops. So if a patient's on timolol and they're not getting adequate pressure control, then I'll see somebody switch to brimonidine, and then they still don't get adequate pressure control. What you need is to add them. So instead of going from, say, Combigan to dorzolamide, you should go from Combigan to Combigan plus dorzolamide, so that you're actually adding drops rather than switching drops, in order to get more of an effect, because each of the groups of drops has a different mechanism of action. The second thing I'd say is, if I have a patient who's a glaucoma patient, they're getting OCTs at least once a year anyway, where I'm getting a retinal nerve fiber layer OCT. And if I'm doing that, I'll just get the macular OCT anyway. So any patient in this person's situation would have already had an OCT, regardless of whether I was looking at it specifically for doing cataract surgery. Now, I don't actually OCT every cataract surgery patient prior to cataract surgery, because of how billing and everything works in the United States. It turns out that if we do the OCT, it's for free. So the patient, we can't bill for it if we do an OCT and say IOL calcs on the same day. We can only bill for one or the other. So I do OCTs on patients who are getting premium lenses, like multifocal lenses, because of the higher risk if there's an issue of them being unhappy with the result. And I do OCTs on patients who have known pathology. But a patient who has no known pathology and is getting a standard lens, I usually don't do an OCT, and I just let them know, there could be things that we're not seeing, and we'll address them if we have to. But I don't think there's anything wrong with getting a routine OCT. A lot of my colleagues do it. It just turns out to be very expensive for the clinic. And so we try to save some money in some places.
Okay, thank you very much for that. So they actually try to save money in the US.
Yeah, weird, huh?
All right, this has been so exciting, so rewarding, such helpful information that we can apply tomorrow in our offices. We're really appreciative. Now, but who's going to give us the thanks? The thankful man, the thankful doctor, Dr. Dane Levy, will now give the vote of thanks. And he will send us off. I'm out. Thanks.
Good night, Pauline. Let me begin by thanking you, who have done such a wonderful job at moderating this second webinar, this part 2 of this webinar, which is really very, very informative, as you said, very enlightening and very stimulating and encouraging. And I think it has motivated us to be a little more on the lookout for our patients, with encouraging them to do their annual eye examinations and to monitor their medications, to look at their comorbidities, and of course with the emphasis on glaucoma and its detection and treatment. I would also like to thank Professor Williams and his team from Duke, who have dominated this evening's webinar. It has been a real eye-opener, and we thank you for the partnership, sir, with Caribbean College of Family Physicians. I think Dr. Maynard McIntosh would have been instrumental in getting you, Prof. Williams, and your team to participate so ably in both webinars. This the second half being tonight, and we're all together grateful. I say thanks on behalf of the Caribbean College of Family Physicians, and of course our president, our chairman for the Jamaican chapter, Dr. Seni Onanuju, who would have moved the opening remarks and welcome, and would have also been instrumental in organizing both webinars, particularly this evening's webinar. Dr. Arlene Henry Dawkins, of course, led us off with prayer, and I just want to say thanks to Arlene for invoking the Lord's presence, guidance, and of course, his blessing upon us all. To name our presenters this evening, I already spoke of Associate Professor of Ophthalmology, Dr. Lloyd Williams, who speak of the role of emerging therapies in preserving optic nerve function, and he was followed by Dr. Nathaniel Blecher, consultant ophthalmologist, who spoke of the lifestyle and eye health and emphasized nutrition, exercise, and other protective strategies and preventative measures to reduce glaucoma risk, which we as family practitioners can all relate to and implement in our practices. Next was Dr. Stephen Karuba, who is also a consultant ophthalmologist. He spoke of the role of the primary care physicians in preventing blindness and referral guidelines and co-management strategies for eye health. All in all, I think all pointing to the role and function and the important role of the family physicians, the GPs, the first line of treatment in the patients who must be on the lookout for this very, very important condition, which is can affect so many of our population. Glaucoma and quality of life, addressing the psychological impact, very important, presented by Dr. Azim Musa, coping strategies and patient-centered care, all adding to that circle of strategies that we must employ in getting the best results for our patient. AI, the new kid on the block, artificial intelligence and glaucoma, and of course, telemedicine in ophthalmology presented by Dr. Ariane Allen, consultant ophthalmologist, highlighting how technology is transforming early detection and treatment for eye diseases. Very, very interesting. It's a developing area. It's an area that I think will have vast impact on how we treat with our patients and how we access them and how we are able to detect early changes that can lead to glaucoma. Of course, Dr. Maynard McIntosh gave an overview after that and spoke to the importance of telemedicine as well and the impact of AI. All together, I think this was an excellent webinar. And of course, it was technical support was offered by Oldgate Solutions and Sam Aaron being the principal there as usual. Sam, thank you so much. You were on the ball, everything went well, and you were, I mean, very, very efficient. Thank you so much as well. Our sponsors, Bioprist Pharmaceuticals and their range of medications related to eye conditions, all different types of eye conditions. Jordan Huri did his presentation for Bioprist Pharmaceuticals, and I think it was very well received. Our administrative staff, Mrs. Lynn Thompson-Ayat, ably assisted by Suyan Lawrence, who in partnership with the CCFP executive, particularly our chairman, President Dr. Teseni Onanuju, who together have really done a marvelous and remarkable job in presenting the webinars yesterday and of course this evening as well. So kudos to you, Mrs. Lynn Thompson-Hyatt, Ms. Suyan Lawrence, for the support to CCFP Jamaica in organizing this webinar. Our colleagues who participated, of course, it would not have been a success without the participation of our colleagues at the maximum number 203 in all. I think we all benefited from the webinar this evening, and most of us, I think, would have been here last night and again this evening. It is a tremendous feast of information, and I think we will all benefit from both webinars. I think we have been stimulated, I should say, and encouraged and motivated to go that little extra mile and be even more, more careful in assessing our patients when it comes to those who have eye issues. And when we are doing our annual examinations, I think we'll be paying a lot more attention to eye health. So thanks again to each and every one of us that participated in the webinar this evening. It was a tremendous success, I think. And I just want to encourage all who have been instrumental in putting it on. It was truly a success. And I think we're speaking on behalf of all our participants. I think it was a well-executed webinar with loads of information, which we can all use to enhance our practices and to help our patients as we interact with them. So once again, thanks and God bless you all. Have a good evening to one and all.
God bless you too, Doc. Thank you so much for the vote of thanks and stay safe. Have a wonderful evening. Thanks, everybody. Have a good evening. See you at the next one. Cheers.
Cheers, Sam. Thank you.